Outcomes for life-extending treatments are measured in physical units of time. These are further reduced into median and mean progression-free and overall survival numbers. In a clinical trial, the standard approach is to randomly assign a cohort to receive a treatment and then measure how long they live on average. This amount is then compared to the average survival of another cohort receiving a different treatment. All other things equal, we recommend the policy that produces the greater average survival. This approach to policy analysis assumes that each additional year of life confers an additional unit of value to each patient. But what if there are characteristics of survival that are missing, but that affect preference? Then average survival gain may have limited policy value. Here's an example. Suppose we take the same 2 treatments with the same average survivals as before, but we explain that one person immediately dies in treatment A. Our expectation changes and the treatment becomes less desirable because we value proximal years of life more than we do distal years in this case. Or we can make treatment B more desirable by explaining that one person is cured. In this example, our expectation changes because we are valuing distal years more than we are proximal years because the treatment provides hope. In both examples, we've introduced risk, and it seems to be the case that risk may affect our preferences for survival. To evaluate this, researchers at the Schaeffer Center conducted an experiment. They assigned 2,000 persons across the U.S. to a survey. They asked Americans their preferences for survival when faced with uncertain outcomes. They represented uncertainty using medical treatments. In some treatments, all outcomes were bad except for one good outcome. In other treatments, all outcomes were good except for one bad outcome. The results show that when a treatment offered the chance of a very good outcome when all other outcomes were bad, it was most desirable, even though it conferred lower average survival to the population. They also found that when a treatment carried the risk of a very bad outcome when all others were good, the general population preferred avoiding the bad outcome, effectively trading it for lower average survival. What can we take away from this study? Currently, we are measuring population averages. Really, what we should be doing is measuring population preferences for survival.